you know, lots more to talk about and to do. So I am going to start. Is that okay, Sheila? If I start, you're good? Okay.
Yeah, I'll fill in.
So talking about JYNNEOS vaccine today, we're going to be offering this in the Bartlett practice starting next week. Thank you to Sheila for really making this happen. I have no disclosures. I'm going to do there was a delay. I'm going to do just a brief overview of MPOX epidemiology, talk about why we do want to vaccinate, even though we have a small number of, if any, cases right now, and then talk more about the JYNNEOS vaccine itself, some practical considerations. So this is our current US case count. 29,980 cases in the US diagnosed so far and 21 deaths. We lead the world in cases and deaths. Globally, 84,648 cases and 80 deaths. Behind us is Brazil at 10,599 cases and 14 deaths. In the state of Maryland, we have had 3 deaths. As you all know, MPOX transmission is vast majority sexually associated. Most of the people impacted are men who have sex with men, bisexual men, and others who have sex with men, disproportionately impacting Black and African American individuals, and then really significant proportion of people living with HIV. And certainly the deaths have occurred mostly in people living with HIV who are immunosuppressed. As you all know, thankfully, the number of cases has declined really steeply. So now it's a rare occurrence to diagnose somebody with MPOX. Why the decline? Behavior change, education about the disease, and then certainly vaccination as well. This is from the MMWR, where they looked at JYNNEOS eligible men 18 to 49 years old in 43 jurisdictions, and they compared the incidence of MPOX among people who were not vaccinated compared to those who were vaccinated. And the incidence of MPOX was 9.6 times that in unvaccinated individuals compared to people who had received 2 doses of vaccine. And it was 7.4 times that of people who had received 1 dose of vaccine. So, you know, sort of why vaccinate? Because it's protective, because it's possible there could be a resurgence, and because, especially for people living with HIV, there are really serious consequences, including pretty bad death. I don't know if any of you have seen the cases of the people who have died, but it's really quite awful what these people went through with the MPOX that could really not be treated, and that's why they passed away. So in terms of MPX eligibility, really what we're focusing on now is obviously PrEP. This is from the Baltimore City Health Department. They are the entity that's giving us the vaccine. And, you know, originally it was mainly reserved for post-exposure prophylaxis of known contacts of confirmed MPOX, and then it was expanded post-exposure prophylaxis for people who, you know, had a high risk of having come across MPOX. And now it's really pre-exposure prophylaxis for people who have multiple or unknown sexual partners. Again, priority being given to people who are immunocompromised and members of impacted communities, including gay and bisexual and transgender individuals who have sex with men. In terms of the vaccine, so I think, as you all know, the prevention and treatment that we have for MPOX was really designed for smallpox. Nobody was anticipating the May 2022 outbreak that occurred. But because MPOX is in the same family as smallpox, there's some evidence that these prevention and treatment tools would be effective against smallpox, both in the laboratory as well as in, through some limited clinical data. These, prevention and treatment tools were employed against MPOX. So the main vaccine, the only vaccine in Maryland that's available is JYNNEOS. This is a live, non-replicating vaccinia virus. It was designed as an alternative to the ACAM 2000, which is a live replicating vaccinia virus. So as an alternative to that, to fight smallpox for people who are immunocompromised. Because it's non-replicating, fewer side effects, safer for people who are immunocompromised. It is a 2-dose series given 28 days apart, contraindicated in people who have previously had a severe allergic reaction to the first dose of JYNNEOS. Peak immunity is expected about 14 days after the second dose of vaccine. And again, the duration of immunity and efficacy is unknown. I just showed you some preliminary data that shows it is effective in preventing MPOX infection. Here's the vaccination schedule and dosing. Okay, so it is FDA approved for use in the subcutaneous route, 0.5 milliliters. It's been FDA approved for people who are 18 years and older. It is under EUA for intradermal administration, and then subcutaneous use for people under the age of 18. Basically, and that's because the intradermal dosing was approved because it requires less vaccine, so you can give it to more people. Intradermal use of vaccine in to prevent other infections has been proven to be effective. And again, the data that we have comparing intradermal to subcutaneous shows that it is as effective and works well, including in people who are immunocompromised. The primary route that JYNNEOS is being given is intradermal, and that will be the case in Bartlett. The exception is people who have a history of keloid scarring. They should get the subcutaneous dosing. We are not currently giving any JYNNEOS to people under the age of 18. So more on JYNNEOS. In addition to the contraindication I told you about, there are some precautions. So if someone's had a history of severe allergic reaction after gentamicin or ciprofloxacin, or severe allergic reaction to chicken or egg protein, and they are currently avoiding chicken and egg products, just a precaution, they should be observed for 30 minutes after vaccination, and just, counseled. If people have moderate or severe illness, consider deferring the vaccine to a later date until they feel better. Typically, you can give JYNNEOS at the same time as other vaccinations. If JYNNEOS is given first, you might want to consider giving COVID-19 or the mRNA COVID-19 vaccine delayed by 4 weeks. And this is because with the ACAM 2000, there were some reports of myocarditis or pericarditis. And we know that there were also reports of myocarditis, pericarditis with mRNA vaccines, particularly in young men and adolescent boys. So it's something to consider. If the COVID-19 is given first, the vaccine, then you don't need to delay the JYNNEOS. In terms of side effects, not everyone experiences them. The most common ones are redness and itching where the vaccine was given, headache, tiredness, nausea, chills, and muscle aches. The intradermal dose of JYNNEOS, the local side effects may be more severe compared to the subcutaneous dose. And some local reactions, including hyperpigmentation, may persist for several weeks or months. So patients should be informed about that. Liz Gilliams sent me these images from a patient of hers who had a pretty significant local reaction to intradermal JYNNEOS vaccine. So you can see 12 hours after the dose, what the local reaction was, and then 12 hours. And then after 36 hours, it got much worse. The patient went to the emergency room, got prescribed an antibiotic, spoke with a Bartlett ID provider, and the patient was, counseled that this is a side effect from the vaccine. They stopped the antibiotic, and then the erythema and edema and warmth decreased. And then Liz has these helpful management tips, including ice pack, oral antihistamines, and that the CDC recommends avoiding topical steroids and topical antihistamines.
Joyce, can I just ask quickly, that kind of
Yeah.
looked like an exuberant PPD response, which occasionally, if it gets really bad, you do use a steroid in that setting, but not a topical and oral, if I'm not correct. It's been, I don't know, decades since I saw that. But Liz, is there a contraindication to using, if someone has a very severe reaction, have you ever observed that or heard of needing to use a steroid for that?
I haven't heard a lot of information about management of like really exuberant responses like that. And I also am curious about the contraindication for topicals as well. I wasn't able to find a lot of good information about that, but nonetheless, it's on the CDC website.
Thank you.
So then, in terms of how to order the vaccine, I'm gonna give a plug again for Smart Sets. We set up these Smart Sets. If you search Bartlett, we have facility administered meds, we have the immunization Smart Set, and we have the pentamidine administration Smart Set. If you search for it and then you fill in the star, it will come up. It will come up as a favorite. You get to it by, in the plan section, clicking on Smart Sets. And once you favorite it, these are my Smart Sets, you can then click Bartlett Service Immunization Smart Set. The MPX vaccines, those are not in there yet. They're not in there yet, but they will be coming. So please add this to your Smart Sets. You can see the other ones that we have. It will then preferentially show you the intradermal route. And then
Joyce, they are in there, and I was gonna show that. I have the Epic Playground up.
Well, they're not in production yet. So they're in the playground, it sounds like. Because I looked today. I looked just before this talk. So maybe they made it live because I sent them an email that it wasn't live. Did you just look just like 10 minutes ago or something? Anyway. They were not there when I looked maybe an hour and a half ago.
And my understanding is for the interval, you have to add, so this was something that I was gonna go over. You have to put in every Q4 weeks in that interval box.
Okay.
For a count of 2. You did that correctly.
No, this auto populates in the Smart Set.
Okay.
So
we'll see how it goes on Tuesday.
okay, well, I'll look at it, again. So if you check the box, then you'll see both of these options. You want to choose the intradermal route. There's a reminder that for subcutaneous, it's for keloid forming patients only. And then you can also, search for it. So if in your orders you search for MPX, then you want to choose, again, the intradermal route. All right, so that is the presentation. Let me stop sharing my screen. Okay.
So,
and actually, one quick question before we move on. Joyce, in terms of identifying who should receive it,
Yeah,
Like, what is your recommendation practice? I mean, currently rates are so low. I've had a couple of people who've actively been seeking it, but
Yeah.
you know, of all the vaccinations that I am usually trying to get people to take, how are you thinking about prioritizing this one?
yeah. I mean, I think, like it said, people who have multiple sex partners, people who have anonymous sex partners, people in whom, if we did have a lot of MPOX cases, you would be worried that they would get MPOX. That's who I think should be, and I think others think should be getting vaccinated. Of note, people who, and I should have put this in the slide, people who have had an MPOX diagnosis, CDC is not recommending vaccination at this time.
Thank you.
All right, Sheila. I
Hi,
hope we
everybody.
used enough
So
time.
this is my fault. June Rice is here with me too, who's been
Hello.
wonderful with my MPOX evaluation and treatment here in the clinic, and she's been helpful to me in getting the vaccine set up in the clinic. So it's so funny. Joyce's first slide was my first slide. Joyce and I clearly did not talk to one another. So that's fine. And I was going to show you the epic playground, but it seems like Joyce has already done that as well. So I'll try to fill in some of the blanks of what I think is important for the workflow here in the clinic, in that so really anyone who we believe, is at risk, we should be giving the vaccine to. We're not giving it to people who have had MPOX in the past. We're being told that the vaccine is supposed to provide lifelong protection. I think it's going to be really important that that the providers educate patients about this vaccine. I just don't want it to be ordered and that CMAs are the ones doing the education. They shouldn't be the ones that are doing the education, and that a determination is made by your order that someone does not have keloids or doesn't, form keloids, and that we can give it to them intradermally. And if they need to have it sub-Q, we will give it sub-Q. Because again, how the MAs will draw it up will be different. They will use a whole vial if it's for somebody that they're giving it to sub-Q. And if they're giving it intradermally, they will be able to get 4 doses out of a vial. The vaccine will be good for 8 weeks in the refrigerator. So the MAs will not draw up vaccine in the morning like they have with COVID, because we're going to wait till a patient gets here and there is an order for vaccine before we draw up the vaccine. So it sounds like if you do it via your preference list, the orders are already in there. I was just told to make sure that you put in the frequency as every 4 weeks with a count of 2. So I was going to go through that in Epic because I just want to make sure that the second order gets in there.
Yeah, so that's the idea behind the smart sets,
Okay.
is that we are allowed to sort of pre-populate for our clinic
Okay.
things that don't come up when you just order it. So,
Okay.
when you just order it, it doesn't have pre-populated like the 2 doses and in the sort of hopefully helpful information. So that's again why I have a plug for, favoriting all of our all of our smart sets that we've made for Bartlett.
Okay.
And-
Yeah.
Can I just ask one other clarifying question? So I noticed that the name in the slide that you showed was like live replicating vaccinia, and it didn't say JYNNEOS or ACAM 2000. So can you just reassure that it's not possible to order ACAM 2000? So that
It's not possible.
okay, fine.
No.
It took
Just
months.
because it
It
the
took
way
months
it's
to be able to
to order this. Yeah, no, it's just
Yeah.
that like, sometimes you see different formulations of vaccines and the
And
brand
I
name is
asked if it could be clearer, because just even in the historical admins, but this is as good as I was able to make it clear.
So, So what we, when Joyce, her first slide was about the eligibility, I am going to, I'm going to laminate them. I had a slide which had that MPX vaccination in Baltimore City, vaccine eligibility. I am going to laminate those and put them in exam rooms, but I also wanted to share with you other things that will be in exam rooms for your, you know, for you to have. And I will put all this stuff in the Teams channel as well. So again, there'll be administration facts, just about how it's stored, that we'll be able to have it in our refrigerator for 8 weeks. That the intradermal administration dose, can everybody see this? Will be 0.1 mLs. Again, we're going to screen for if the providers can do this, allergic reaction after previous doses of JYNNEOS, a history of developing keloid scars, because of that, then you would orders at 0.5 ml, the subcutaneous administration. An allergic reaction to gentamicin or ciprofloxacin, or an allergic reaction to chicken or egg protein, and that they're currently avoiding all chicken and egg products. This basically tells how the MA would draw it up, how we're going to give it intradermally, how we will give it subcutaneously. If somebody has had reaction to chicken or egg protein or anything else, we're going to watch them for 30 minutes and not 15 minutes. The doses will be 28 days apart. The patients will sign a consent form. It's a generic consent form. We will give them the EUA and the vaccine information sheet. And then if I've told the MAs if they have any questions or any concerns to come to the provider before giving it, because once it's in somebody's arm, you can't take it back out. So, as with any vaccine, if they have any concerns, they will come to you. And then the other one that will be in your room pretty much says the same things about if they had monkeypox in the 2022 outbreak, it's not recommended that they get vaccinated. Patients diagnosed with monkeypox after their first dose are not recommended to get a second dose of JYNNEOS. Immunocompromised patients diagnosed with monkeypox after their first dose can receive a second dose. We already talked about the use of sub-Q administration if they have keloid scars. And then we talked about the allergies. If a patient is seeking a second dose after 21 days, it should be administered as soon as possible. There's no need to restart or add doses. If they got a sub-Q because their first dose was before they were 18, they can get their second dose intradermally after their 18th birthday. If they got the first dose intradermally and they developed a scar, they can get sub-Q for their second dose. I think that's pretty much it. Is there anything I'm forgetting? Yeah. So June and I will be tracking people to come back for second doses to make sure that happens, just like we did with COVID vaccines. We're going to ask the MAs to escort people up to checkout to make sure that they check out to get the second dose scheduled. June and I will look on a daily basis at who got first time doses to make sure that they are scheduled for second time doses. So I think we have some good workflows set up. So if anybody has any questions, I'm not going to show you the Epic stuff because Joyce already did that.
And the sort of minimum interval is 28 days. It can be given 4 days before that. And then the second dose is supposed to be no more than a week, 7 days, 28 days plus 7 days. But like Sheila said, if they're delayed, go ahead and give it and don't revaccinate. And then Eileen, it says in the name says live. It does not say replicating. It says
Right.
says
No,
live.
but it just says live, which I think,
I know.
yeah.
It's confusing, but It's the only one that can be ordered, and Bartlett's the only place that has it. So we're the only ones who can order it.
And I think probably our prep population, apropos of our first case, would be when to really be thinking about the use in. And I'll just mention as a unrelated topic, but one that came up in clinic this week. If someone has not had any COVID vaccination before, they cannot start with the booster. It's a booster. So keep in mind that that's a lower dose and you actually have to do the primary series, even though there's this general thought that it may not have the right specificity, it is still the one that's dosed appropriately.
And then to that point, unfortunately, primary series vaccine is not readily available at Hopkins. Matthew Lengel just sent an email to the clinic about this. So if you have somebody who needs a primary series, Sheila, what are we recommending for those?
So if they need a primary series, we need to call over to the Ames Pharmacy and see if they have any available. Yeah.
Yeah, so because we discussed this with this, our patient had been very hesitant for a long time, and now as part of a green card application is no longer hesitant. But which is great, you know, and actually hasn't had COVID, but there were no options for starting her. And so for the purposes of being considered fully vaccinated, again, just because we reviewed this the other day, once you've completed the primary series and are not booster eligible, you are completed. So it's the timeline to complete that is about 28 days, depending on which primary series you choose.
Yeah, so the number for the Ames Pharmacy to see if they have supply. So the pharmacist that's going to the health department to pick up our MPX vaccine is also the one that oversees all the COVID vaccines, and the supply is very, very small. So the number to the Ames Pharmacy, and the MAs know this, is 50817. And that's the number we're supposed to call to see if we can get any primary vaccine for patients when they come. So that was one of my updates. Good question. Thank you. And then I just have really quick 3-minute other updates that there's still room for trauma-informed care on Tuesday. You can sign up. I will go in there and look again by end of business today and send you the email, because it's not tricky, but you have to swipe up to get into the Vera building to the 8th floor where the training will happen on Tuesday. There's a training from 9 to 12:15. And then one from 1 to 4:15, and you have to use your swipe card to get up the elevator. And then there's a door that you have to key a punch code to get into the door. Lots of security over there. And then there was a patient that was way back on December the 21st that needed psych evaluation in the emergency room. And when security came, there was some concern about taking this patient to the emergency room, although the patient was completely cooperative, not agitated, anything like that. But we had a follow-up meeting, Abby and I did, with the security leadership, and they said when we're having somebody escorted to the psych ED for evaluation, we have to say that when we call, because then they will send 2 security officers rather than 1. Just to know that they don't put hands on anyone unless they are suicidal or homicidal, and that a provider here attests that they need to, they have to be taken to the emergency room involuntarily. But hopefully it won't come to that, and always that our patients will go voluntarily to the ER, but we do have to let them know that it's for a psych eval, and they will send 2 officers. And then the other thing I just wanted to let you know about was, if everybody didn't know, we did follow up on, there was a patient found sleeping in exam room 18 when we all returned to work on January the 3rd. And what seemed to happen there was it was very easy for a new nurse that worked up in one of the inpatient units and was bringing a patient in for remdesivir to open our doors, and didn't know that she didn't relock those doors. So there is a follow-up meeting that's going to occur so that can't happen again. And thank goodness nobody was hurt, nothing was stolen, no medical information was compromised. So I just wanted to give people the update on that. And then just a quick reminder that we are down 2 nurses. I do have 1 nurse who is starting on February the 13th. So that is good news. And that nurse will be tasked with getting people off of our Cabenuva list and getting more patients Cabenuva. So excited about that. And that's all.
Great. Thanks so much, Sheila and Joyce, for your tremendous leadership, and thank you for also getting the JYNNEOS vaccine available. And hopefully we'll anyone who has ideas about how to think about how to access more people at risk of HIV in terms of the PrEP practice at the Bartlett, but also outreach, please do feel free to share them.
I
Okay.
think a sexual health session might be good, Eileen. You know what I mean? Like, because we also have been talking about post-exposure prophylaxis for STIs.
Yep,
you
like
know,
doxy-pep. Yep,
like
right.
that might be a good session to have.
Yeah, that sounds great.
Thank you so much.
Thanks, everybody.
Bye, everybody. Have a great weekend.
Bye.